Hello, this is the first video I'm doing, and actually, I'm training to be a pharmacist in Canada. And during my training, I noticed that many of the guidelines that we are following, um, sometimes we are not so aware of it. We are not so aware of the original source and how they change and so on. So usually we follow like the CPS or similar like tertiary combined sources. However, um, although sometimes the guidelines come first, but we rarely see, or usually on a daily basis, we do not really keep track of the original sources. That's why I thought it would be like a good idea to see these guidelines firsthand and to like dig deeper into them. So just recently, just I was alerted by a friend that there was a new guideline for hypertension. The previous one, I believe it was 2020, but this year there was a new one. And there are some really important changes. And sometimes we usually have this notion that there are fixed numbers like standard 140/90 hypertension blood pressure threshold. But actually, these are change with these guidelines, like we will see here. So, I mean, this is following this paper was published very recently, and this is how these guidelines are communicated. This is in the Canadian Medical Association Journal in May 2025, the hypertension or the new Hypertension Canada guideline. So, just to go directly into it, so here they are taking a pragmatic primary, let's just like pragmatic primary care focused recommendation to improve the hypertension management. I mean, all over this paper, you will see that they are trying to simplify things. So they are still like talking about adults higher than 18 years old, evidence based, and they are talking about the diagnosis and then the treatment. So the definition of hypertension, which comes to the diagnosis, the measurement, and then the treatment. The major differences is that now they have a uniform definition for hypertension being above 130/80. Before it was actually differed for diabetes patients or normal patients. Also, there was hypertension, the high risk. However, now it's all 130/80, and the target is to get a systolic blood pressure of lower than 130, as you can see here. So now I believe it's just like more streamlined, and this is what they are arguing here. Um, and then let's get more into that. This is just an introduction. Now it's around 25% in Canada, and actually, after they lower the threshold, it seems that the numbers will increase because since now the new definition is 130/80 instead of 140/90, so the numbers will increase actually. However, it's not the actual condition that worsen, but just the new definition. In their approach, they followed the World Health Organization. This is a HEARTS method, I believe, just for the way they conducted the research, as just like healthcare professionals, like the people who are really interested in that, who apply that on the ground. What really are of interest are the new guidelines and how to implement them. So this is intended for all the primary care providers because usually the blood pressure management is a primary care issue. So mainly the family physicians, the nurse practitioners, nurses, and pharmacists. So now when we come to the diagnosis, the strong recommendation here is that we need to use a validated automated device and use a standardized method. And this is just nothing new. However, what I would say that is new here is that they focused on the out of office blood pressure assessment as the main recommendation. And the thing is that the ambulatory blood pressure monitoring is more closely correlated to the cardiovascular events and death more than the office blood pressure. So here they strongly argue that we use the ambulatory or the out of office blood pressure measurement also in order to detect any white coat hypertension, which is like the higher measurements when taken into office, and also the mass hypertension, which is like it's not detected in office but detected outside. So, I mean, in general, they put more emphasis on this ambulatory one, mostly because it's more correlated to the practical cardiovascular issues. And then they took another, when we go into the measurement, I mean, like I don't think there is anything new here. However, of course, sitting position, back supported, the standard default, the standard position, bare arm, supported, heart level, they did not mention it here, but I believe this is a standard. And then no, do not talk or move. Legs should be uncrossed and flat on the floor. And then the quiet and calm conditions. Of course, no, very important, no caffeine, no smoking, no exercise for 30 minutes. Sometimes it was set 30 to 60, but here they put it at 30. And then measure at 1 minute intervals, average and record. And now we go to the definition. This is the most important thing. Here, the definition now is 130 over 80. This is very, very important. And their rationale here is that they want to set the threshold to define hypertension at a threshold that is more practical, and they set it at 130/80, which is lower than what was previously. And they say that the data on the relationship between the blood pressure and the magnitude of the cardiovascular risk was their main guide to why they set this number. After that, they mentioned that the lower threshold will increase the number of people labeled as hypertension. And of course, the recommendation is to maximize the benefits of earlier management in preventing long-term complications. So this will help people who were previously would say pre-hypertension now will be considered officially hypertension and will start management. However, there is a trick here is that if the blood pressure is above 130/80, the first line here is the healthy lifestyle, not directly the pharm, as we will see later. When we talk about healthy lifestyle, it's nothing so different from before. I mean, we are talking mainly about the dietary salt intake to decrease it a bit. They found that there is a decrease in when people above 60 reduce their salt intake, there was a 13% decrease in the cardiovascular events. So the recommendation less than 2 grams per day. This is I don't think there is a much change from before. However, they also stressed the importance of potassium intake, of course, with the exception of conditions that have problems with potassium, like kidney diseases or ACE or ARBs and mineralocorticoids and so on. However, for normal patients, higher potassium intake above 3.5 grams, unless contraindicated, would be also important or recommended. Obesity, also a major factor for hypertension. Decreasing the blood pressure, decreasing the body weight will help a lot in managing hypertension. Regular exercise, reducing alcohol, and reducing smoking. I mean, weirdly, that smoking here, they find that the evidence is modest. However, we all know that the importance of quitting smoking for many different reasons. Okay, so now they prioritize the foundational role of the healthy lifestyle stages. However, if it increases to above 140/90, here comes the pharmacotherapy. So this is important that although the new threshold is 130/80, however, the pharmacotherapy still starts above 140/90, which is very important to note. And also above 130 in case of any cardiovascular risk accompanying the hypertension. So when they say cardiovascular risk, they mean these cardiovascular disease, diabetes, chronic kidney, FRS score of more than 20%, or age above 75 years. I believe these were the same conditions of the high risk patients that they in the previous guideline. So if a high risk patient, they put the pharmacotherapy starts above 130. However, normal patients start above 140/90, although their definition of hypertension is still 130/80. The 10 millimeter mercury difference here is managed by lifestyle. If they cross the 140/90, we start the pharmacotherapy. So what is the pharmacotherapy? The most important question here. So mostly, in addition to lifestyle changes, we go to before we go to that, there is an important point here. They say that in previous guidelines that the systolic in high risk or the high risk patients, the systolic blood pressure was less than 120. This was the previous target. However, here they put it as less than 130, and they say that in practice 120 was too strict. So that's why they increased it to 130. So now the new target for the high risk patients that are considered high risk hypertension Canada patients, the new target is less than 130 systolic instead of 120 systolic as before. Okay, now this makes it more streamlined, more simple. Now we go to the therapeutic recommendations. For therapeutic recommendations, the first line is a low dose combination therapy, ideally a single pill combination. And this includes two out of the three main classes, which are the ACE or ARBs, thiazide or thiazide like, and the long acting dihydropyridine like amlodipine and nifedipine. Of course, it must be long acting. This is a must for hypertension. So they argued here that beta blockers, they put it out of, I mean, it's now fell out of favor. It's completely not, I mean, they did not even mention it, and they say that it has a lot of adverse effects. It's not recommended as a first line therapy anymore, unless there is another need like heart failure, angina, or other need for the beta blockers. But if no need, then it's not a first line. So just of course, an important note that ACE and ARBs are teratogenic. They have their own problems like in kidney disease and so on. So this would be a case, a different specific case, but in general they are the first line unless there is a problem with them. For before thiazide like were preferred over thiazide, but here they say that the efficacy is not so different. So it's thiazide or thiazide like. And the first line would be an ACE or R plus thiazide or thiazide-like or a calcium channel blocker. So they say, of course, and was in line with before, the additive blood pressure lowering effect, minimizing adverse events, cost savings, and so on. And okay, now the second point, if the blood pressure remains high, then despite the two drug combination, then a three drug combination consisting of ACE or ARB, thiazide, thiazide-like, and the long-acting calcium channel blocker is warranted. So here, recently they say a single pill of the three classes was introduced. It's not available in Canada yet. However, it seems it could be available soon. But anyway, it could be like different medications for now. But later on, it seems that a single pill of the three drugs could be there. If this fails, then we go to spironolactone. However, we take this with a pinch of salt because they say that spironolactone has its own adverse events, gynecomastia, due to anti-androgen effects, and also the hyperkalemia. However, they still see the benefit of it. However, the evidence, actually they put it in a table here, the evidence for the spironolactone is conditional. This is the only one. You can see all of this is strong. However, when it comes to the spironolactone, the evidence is not strong. This is an important point, I believe. And then let's continue. Okay. And then, yeah, now we go to the just like a summary, which is very nice algorithms. So here for diagnosis, hypertension is suspected, and then we do an office blood pressure measurement. Is it above 130/80, the new threshold? If it's not, then there is no hypertension. If it's yes, we do another out of office, like earlier they emphasized that. If it's still above 130/80, because this could be a white coat hypertension. If it's still above 130, then it's hypertension. Otherwise, it's a white coat. This is a very nice algorithm, streamlined. Now we go to the management. If we already know there is a diagnosis, then our target is a universal target. It's less than 130 millimeter mercury. And then we see now if the patient is above 130 but less than 140, so from 130 to 139, and the patient is not a high risk, then lifestyle changes are enough, and we reassess in 3 to 6 months. If the blood pressure is above 140/90 or above 130 with a high risk, then pharmacotherapy must be there. When we do pharmacotherapy, we start first with ACE or ARB plus thiazide or thiazide-like, and then we see what happens. They mention here we try with, like, let's say for example a low dose first, and then they put it 150 12.5, and then we go to a higher dose, and if it doesn't work we add the calcium channel blocker. It doesn't work, we add the spironolactone, and then this will be like a big deal if the 4 steps don't work. This I don't think, as pharmacists at least, we will not see that, or primary care providers in general. So let's see examples. For example, we can see here R plus thiazide or thiazide-like irbesartan, telmisartan with hydrochloro, and ACE, lisinopril, perindopril with hydrochloro or indapamide, and or the R plus calcium channel blocker amlodipine. So compared with the 2020, what changed? The present guideline encourages the initial low dose combination. So now this is the streamlined standard. And of course, they adopted the 130/80 threshold instead of the 140/90, and also the target universally less than 130. Yeah, that's about it. I found that these guidelines, actually digging into the original papers, is very, very important. Maybe I'm still like training for the role, so that's why I find this really exciting. But I believe some of you would share also my interest. And later on, I will follow up with other similar guidelines that can help us like find the original sources of the numbers and all the algorithms that we keep studying. And thank you.